Namaste friends. Today I present a case of a middle-aged gentleman who presented with delayed trauma and rupture of spleen. The patient had undergone bike accident 1 week ago. At that time he had no symptoms, but suddenly he presented with hypotension, and when he was stable, CCT was done. It showed splenic laceration grade 3. So we thought to manage conservatively, but hemoglobin started to fall within 6 hours, and his BP was coming to lower side. So then we decided for lap because the patient is extremely obese and laparotomy would be very difficult, and we were doing case at 1 a.m. So we initially proceeded with a diagnostic lab. As we entered, we could visualize hemoperitoneum. The blood was seen in the upper quadrant and clots were seen. Patient had stable course throughout the procedure. That's why we proceeded with the laparoscopy. And in a trauma, laparoscopy is reserved for very selected patient and quick response is needed. So it is not recommended for the beginners. See, that is the blood and the clot. Because of patient's huge abdomen, we were struggling with the port placement and maneuverability of the instruments. We are seeing this after extreme left up and head up position. Now we can see the spleen and it is densely packed with the momentum, and it's very difficult to visualize the vessels in situations like this. A open situation will cause more trouble, or the difficulty is with the huge incision that has its own problems in the post-op period. So till now we have no issues, so we are proceeding with the laparoscopy. We start dissection from the upper pole of the spleen, where obviously there won't be any vessels, but we are very skeptical, as we are not visualizing any blood vessels directly. See, this is the trauma part, and the spleen has ruptured into its capsule and it has formed a bleb, and we can see the superficially the broken ribs. So now I continued with the inferior pole and superior pole first. Now I am entering the lesser sac. As we can see here, there is thick pad of momentum, which is not at all opening up or giving visualization of the lesser pole or lesser sac, sorry. I am proceeding slowly because at any time our open set was ready for open procedure. Now I am doing dissection in the lower pole, where there are no obvious vessels. In trauma it is very difficult, that too in a delayed trauma we should expect vessels in every plane. So now what I am doing is I am opening up the superficial peritoneal layer of the pancreatic tail to delineate hilum. As I am seeing here, it is filled with fat and I am not able to see the individual vessels. Now the only path is to identify the superficial branches and cut it. Now I am dissecting the short gastric vessels, that is in the gastrosplenic ligament. I'm dissecting the excessive fat that is coming into our field just to get clearance. Is shifted to lower pole. I thought there is no blood vessel in that superficial layer, but suddenly it started bleeding. Here I opened the lower peritoneal layer. Suddenly the blood started coming. So here we have a vessel. In trauma, the important thing is to identify the source of bleed. In laparoscopy, the difficult thing is bleeding. So here what I have done is I have used a blunt intestinal grasper to grasp the bleeding point. I have used a gauze here, as we can see here, to localize the bleeding. In left hand, I am holding the bleeder, as you can see. So I used hemlock clips. Now I release the pressure. The bleeding seems to have come down. So I am placing one more clip proximally so that the bleeding will be completely stopped. See, one more clip proximally. Now I release the pressure. Now the bleeding has reduced to a significant extent. Throughout the procedure, I have used only hemlock clips as I am dealing with the terminal vessels of the splenic artery and splenic vein. In these situations, if you think that bleeding cannot be controlled, it should be converted to open. The decision to convert open depends completely on the surgeon. As we can see here, there is still some amount of bleeding. Again, I use the same principle. I just took the proximal control so that I do the suction to clear all the clots in the vicinity. Using gauze helps greatly to do suction. So now what I do is I remove the gauze to visualize where is the exact bleeder. In an abdomen like this, it's very difficult. See, now I just visualize the bleed and I put a clip. Even after clipping, there is some amount of bleeding, so that can be managed because the darker bleed is from the specimen. That is okay. Now I am using harmonic to cut the proximal part. We don't have to put any clip near the spleen. I have just put one clip to reduce the specimen ooze, but that is fine. The major difficulty in laparoscopic splenectomy is to control the bleeding from the specimen, which confuses us with the bleeding from the source that is usually in dark in nature. If the bleeding is from the splenic artery, it is spurt and it can never go unnoticed. Now again, the bleeding has reduced, but the specimen bleed has piled up or collected in the dependent area. Now the only thing we have to do is we have to go slowly from lower pole to the upper pole, which is the only way for us because the upper abdomen is completely fatty and the route for lesser sac is obscured. And see, that is kidney, and we have few attachments coming from the upper pole of left kidney to the spleen. We should be very careful in dissecting the loose areolar tissue. We should not go deep because lienorenal ligament contains adrenal vessels. That is very difficult. So now the lateral attachments are being freed up, which are usually avascular. Lower polar vessels are seen here and they are clipped and cut. Even though they look benign, I am not taking any risk. I am clipping each and every possible vessel and I am using harmonic to dissect the proximal part. I am not using any proximal clips to let the blood drain from the specimen so that the specimen size will be less. Or few surgeons will say you control it now and while retrieving the specimen we can do all this retrieval of blood. That depends on the surgeon's preference. Now I am proceeding with dissection of loose alveolar tissue that is being attached to the lower pole of the spleen, to the colon and lateral part of the abdominal wall. Section is continued and any tubular or vascular structure that is going into the spleen is meticulously clipped doubly. A single hemlock will not be reliable, so it is better to use multiple hemlock clips which is occluded properly. Any day hemlock clip will be better. Whenever we don't have hemlock, we don't have to worry. The proper placement and sealing effect of the Liga clips is obtained if it is applied properly. See again one more polar vessels is seen and we have to clip it. The dissection is started and it is going up, dissecting all loose alveolar tissue on the capsular structure. We have to be very careful with the anatomy of spleen. We should know which type of blood supply is present in each and every case. It can be by two major vessels or multiple polar vessels. Now after clipping of these vessels, as we can see here, the spleen has become pale. The dissection is continued slowly. As we can see here, the superior dissection is very difficult. So the only way towards dissection is to dissect from below by ligating individual vessels. Procedure of clipping is continued whenever we encounter bleeding. The moment we clip, the bleeding is reduced, and there is some amount of bleeding from an individual vessels. What we are doing is we are putting an individual clip. See, the moment we applied it, the bleeding has stopped. See, the bleeding has completely arrested. Since splenic artery is a very big artery and it is direct branch of aorta, even a bleeding for few seconds will cause loss of visualization and loss of plane. We have to be very careful. Coming to the upper part, we are approaching it from the lower pole. As we can see here, the thick fatty layer from the stomach to the spleen is seen here, and whatever blood that is there is collected blood. We have to be very careful while dissecting. We should dissect after proper visualization only. While doing all this dissection, one of the clip got displaced. See, so we placed a clip surrounding that to prevent bleeding. These are the individual clips, as you can see here. The bleeding has stopped, and this is a basal clip which we are applying. See, the moment we applied it, the bleeding stopped. Now we have dissected the spleen all around. You just have to pull it up. It's really coming, and there are no attachments. Now the spleen is completely mobilized. Now the difficult task is to retrieve this specimen. So for this, what we are doing is, we have used a sterilized Eurosac bag. So we placed the spleen inside this bag, and then we are retrieving through it. It is initially difficult to maneuver this, as the spleen has smooth surface. One advantage of huge abdomen is easy maneuverability. We can maneuver instruments and placement of the specimen into this bigger sac, Eurosac bag, easily. As we can see here, it is difficult to place it. So once we placed it, the normal grasper that is used for lap cholecystectomy is used to pull, and I am cutting the facial incision. So now what I have to do is, I have to use my finger to do the finger fracture. As you can see here, the the whole bag, the cover is moving, and I have to fracture the tissue and I have to remove it. While doing that, what happened is the urosac bag gave way and some part of the spleen left in the abdomen. Now what I am doing is I am using IV cannula cover. Again I am placing this the leftover spleen into this cover, but the cover is small. So what I am doing is I am just cutting up the specimen so that it can fit it into the IV cannula cover. After making 3 more pieces, we could easily place the specimen inside the cover. Now I have placed all the specimen inside it. Now again same principle is used. I am pulling the specimen cover along with the grasper through the facial defect. Again I am doing the finger fracture technique. See, now it is very well visualized. After sufficient fracturing, the specimen is retracted. See, it is almost morcellated. So the rest of the specimen will be taken out by sponge holder or stone holding forceps, and final bits are removed through the facial defect. Now this much big facial defect, around 20 mm, should be covered. I am using figure of 8 stitch here to prevent facial defect hernia formation. Now finally I gave wash and then I am placing the drain. The surgery was done in midnight, and those are the ports, and this is a specimen. A major incision is saved. Thank you.